Thank you, Dr. Afifi. Okay, let's continue on. Our next symposium and our final one, continuous regional anesthesia. He's a international Islamic University Malaya lecturer and had his diploma of regional anesthesia from Montpellier University. Also a member of SIGRA and a student of the well-traveled Philippe Marquet. So introduce to you Dr. Muhammad Rashdan Abdul Ghani to chair the next symposium. Round of applause, please.
Okay, thank you very much. Symposium 5, I know this is quite 4 o'clock time, but I think this is one of the important topics for regional anesthesia because we have the debate, is either single shot or continuous. Alright, so I think I would invite our first speaker, Dr. Pryambodho, from Cipta Mangunkusumo Hospital, Faculty of Medicine, Indonesia, to give his talk about should our blocks be continuous. I invite Dr. Pryam. Thank you.
Can I have the mic? No, it's connected. Oh, is that? Okay, thank you, Mr. Moderator, Dr. Muhammad Rashdan, for a very nice introduction. So this is our topics, last but not least. This is me. I'm from Jakarta. Yeah, it is a nice view, yeah? But don't do this. I can guarantee you it's a wrong pose. Why? Yes, I got a wet pants after that. But at least I got a very nice photos in it. So this is my hospital. Cipta Mangunkusumo is an old hospital, more than 90 years old and still developing. And I'm also working at a faculty member of University of Indonesia. This is our campus. And now we have a very nice new building for research center. And this is our website. And this is not my goal. I know it's an injury time. It's the last topics. But my objective is like this. I hope that after this we can understand about the indication and contraindication for continuous peripheral nerve blocks, and we know the advantages and disadvantages of that blocks, and to compare between the single shot and the continuous one, and compare between the continuous and opioid for post-operative pain management. Okay, what is continuous peripheral nerve blocks? At least we can say this, if we want to re-inject the local anesthetic without doing ray puncture, isn't it? Sometimes we want to do it. More likely that we want to prolong the analgesia for intraoperative, but I think not much operator want to do the surgery very long time for. So most of the time we want to do the continuous block for post-operative purpose, so that we can put some catheter. But a long time ago, when the first continuous blocks was invented, they don't use catheters. They use the needles and they stuck it on the cork and they just tap it to the skin of the patient. Maybe it's hurt, yeah? It's hurtful, it's painful. So now we insert catheter there, and we have to make sure that the tip of the catheter should be very close to the targeted nerve. Maybe all of you have known the stimulating catheter. Any of you have done the continuous peripheral nerve blocks before? 1, 2, okay. Any of you have done the peripheral nerve blocks without catheter, single shot? Okay, many. Any of you have done the ultrasound guided peripheral nerve blocks? Good. So I think my duty is quite easier because I think all of you have understand the main of topics. Now we can, since the ultrasound now become the prime equipment for doing the blocks, it's more easily for us to insert the catheter successfully near the target, since we can see the catheter under the ultrasound guidings. But if we're doing under the blind technique without ultrasound, be careful. Some experts may suggest us that don't put your first local anesthetics under with your needles, through your needles, but put it under your catheter. After you put the catheter, you inject the local anesthetic, and you can see whether your block is working or not. It means that your catheter is sitting on the right position or not. If you inject your local anesthetic with your needle, it means you have doing the blocks, and then you insert the catheter. You have to know that whether the analgesia is from the needle or from your catheter. So that's you must be careful. But using ultrasound, you can check where your local anesthetic spreading using your catheter injection. So we know that using peripheral blocks, we have to educate our eyes. It means another training, but no problem. It's very useful for our daily works, not only for peripheral nerve blocks, but also for any kind of our works in anesthesia. So indication is less likely here, but most of the time for post-operative pain management, either hospitalized patient or ambulatory patient. And we can do also for acute non-operative pain management, like have been mentioned by the previous presenter or speaker. Or for the chronic and cancer pain, they call it is on-arrival block as a rescue before we continue with the with the more permanent blocks. Or we can do it for sympathectomy after vascular trauma or surgery, or for the treatment of vasospasm in renal disease. If I know all of you have done the epidural continuous, are you? Yeah, so the contraindication is the same. So I skip it and let's continue to the location. So this is the location where we should put the catheter according to the surgery. If the surgery is at the shoulder, so we must put it in the interscalene hip. We put it on the psoas compartment or fascia iliaca block or femoral blocks. It's still debatable, but at least it can block the femoral blocks, the femoral nerve, which innervate the part of the hips, but not all part of the hips. So it can reduce the consumption of opiate post-operative rescue. And for ankle foot, we can put it on the sciatic, either proximal or at a popliteal level. And we suggested to add femoral block if the ankle surgery is major one. For children, so many articles, you can find it in the internet. So I think there's no debate about the using of continuous peripheral blocks in children. It's working and it's safe, as well as in the adult. So why we choose a continuous other than single shot? Single shot produce excellent analgesia, but continuous produce excellent plus flexibility of duration and density of blocks. Why so? For example, trauma surgery, we do single nerve block. For example, psoas compartment blocks and femoral blocks for cruris, for tibial fracture maybe. So single shot can produce analgesia for more than 20 hours, maybe more than 24 hours, or maybe some of us may find it more than 24 hours, maybe 36 hours, it depending on how much local anesthetic we give to the patient, how much the volume is it, and also the concentration must be high. For bupivacaine, we must use 0.5. Using 0.25, it cannot last to 20 hours. Is it? So, that's the problem. That's the problem of single shot. Dense motoric block. So maybe your patient did not complain of pain, but she or he complained of cannot moving his leg. I have some of my patients like that. So be careful of this patient. Although they have free from pain, but they're still complaining a lot of paresthesia. So, at this case, we can use continuous nerve blocks. Why? Because we can control the length of analgesia So because we can reduce the volume, and when the patient already feel that the working of our block is almost end, we can add another more volume of local anesthetic using the catheter with a lower concentration, so we can preserve the motoric block, and we can preserve also some sensory that which has lost if we using the higher concentration. For example, if there are a compartment zero post-operatively, the sign could be masking by the single block if you are using a high volume and high concentration of single blocks. So be careful. And then that's advantage of single blocks. Single blocks need high volume, high concentration, while the condition one we can use a smaller number of volume and also the concentration. It means the risk of toxicity also less. And also the risk of fall trauma after surgery for mobilization also less. And we can use opioid post-operative analgesia fewer number. So it means it can reduce the opiate-related effects, fee like that. That's better compared with the single shot. It is some references you can find in many literatures, but the number maybe differs, and that's it. That's how we use that's how we do the continuous peripheral nerve blocks. We cannot just stick on one numbers, but we have to tailor the volume and the concentration according to the patient condition, the patient body weight, and the tall, and you must know that. And also, we can connect the catheter to PCA, either with or without basal infusion, but we have to consider also the demand bolus is vary from patient to patient. This is a very quite interesting study from Brian Eilfield about the determinant factors for using continuous peripheral nerve blocks. Is it the local anesthetic concentration and the volume, or simply the dosage, the milligram of the local anesthetic? So he used he recruit patient with hip arthroplasty, and they give same milligrams, but in one group with 0.1%, one with a higher volume, 12 mils, and the other groups with 0.4% but lesser volume, 3 mils, but the overall still the same. And what the study said, it has the same degree of motor blocks. That's interesting. So it's depending on you whether you want to use the high concentration with low volume or high volume infusion with a lesser concentration. Is still debatable. But the best is to titrate. We cannot just rely on our instruction to the nurse, gives this volume, give the concentration, and just going home and just like you said, turn off your cell phone. You cannot like that. We have to titrate. After we put the first instruction, we have to examine again, evaluate whether our recipe is suitable for the patient or not. Okay. Does continuous peripheral nerve blocks provide superior pain control if compared with opioids? This is meta-analysis from Richmond and his company. And the results, I just straight to the results. CPNB analgesia, regardless of catheter location, provided superior post-operative analgesia and fewer opioid-related side effects when compared with opioid analgesia. That's the good news. So, it is a meta-analysis, and this is what they found. Compare with the opioids, this is the catheter groups, this is opioid groups. This is the mean pain score, 24 hours, 48, 72. All are better than the opioids. What about the maximum fast score? Also the same. So they have a very strong recommendation for us to choose the continuous peripheral blocks compared with the opioid post-operative analgesia technique for giving us a very good pain score post-operatively. And here also the side effects, nausea, sedation, pruritus is lesser than the opioid groups. But of course, using an local anesthetic, the sensory motor blocks problems higher than the opiates. And we can also use it for ambulatory peripheral blocks, but of course we must be aware about the complication, because we will send the patient home, who will look for the patient at home, who will observe the patient at home, and we have to know how to deal with the complication, to prevent the complication, and how to deal with the complication. So one complication that might exist is infection. According to the Capdophilia and friends, if the catheter is put there for more than 48 hours, this is the highest risk of the infection compared with the 24 and also the longest one. I don't know why, but this is the data. And also, when the block continuous was done for axillary and femoral, more infection will be the risk other than the interscalene and popliteal. And also, we have to keep in mind our mind to avoid this, to do this, to remove our watch and everything. We do the and antiseptic techniques completely before we put the catheter in, while the tunneling catheter is only a minor subject or minor factors that may contribute to the infection. So there are 5 reported risks: duration of catheter and position of catheter, axillary femoral. Other is if patient was sent or stay in intensive care unit, the patient was sent to get the infection. If there is an absence of antibiotic prophylaxis, the patient also higher risk of infection. And also the frequent changing of the dressing. Frequent changing is interesting, isn't it? But I think it's a frequent changing without doing the aseptic technique in the proper way. This is the problem. But if you doing it in a very sterile manner, I'm not sure the result will be the same. The local anesthetics infused is not the source of infection, provenly here. And also the technical aspect, how we put the catheter in, is not the big issue for infection. Other than infection, we have a device malfunction. So be careful about sending patient home who will deal with this malfunction. The catheter can be broken, dislodged, or the pump disconnect, or the battery is running out, or the infusion leaks there, or the first day the analgesia is okay, but the next day there is an inadequate pain, patient suffer from pain. What's the problem? We have to make sure and somebody has to evaluate every day. And also the numbness, I've mentioned previously that this can be the big source of complaining from the patient. Not the pain, but the numbness. The patient feel no pain, but the patient feel numbness, and the patient still complaining. And also the post-anesthesia interfere with the patient care. For example, if we using the stimulating catheter, if the patient after the procedure sent to the MRI and doing the scan, it can produce a much pronounced artifact at the image. And also location of catheters. If the catheter is long enough, so the patient wants to move his or her arms, it can be dislodged or easily cut off by the movement. So it has to be put in mind before we send patient for ambulatory continuous peripheral nerve blocks. For preventing complication, those complications, of course, sterile techniques. There's no doubt, there's no debate about that. We have to do it properly. About the dressing, the type of dressing is not it's not very important, but we have to make it very firmly. And the next presenter, I think, will discuss about this. And so also we have to look at the site puncture assessment, whether it is still good or become reddish, inflammation or not. Standard of care, it is same whether patient is in hospital or we put her in ambulatory. There must be a periodical assessment for the pain for the puncture site and the dressing, the connective, the motor strength. If the patient was hospitalized, maybe we have painters to do the job. But if the patient sent home, maybe one of the family, which is mature enough, can have a good responsibility. We have to rely on that family. And for pedicle change, infusion bag and tubing, make sure that it should be done by the nurse or the doctors. Don't let the patient by themselves change the bag of the local anesthetic. And when putting bag changes or put the bag for initiation infusion, make sure we do the double check. Not only one person that do this job. It should be more than one. Either nurse or doctors or both, it's no matter, as long as it's not one. And also, it has to be a system that makes sure the quality of improvement process day by day. If the patient sent home, maybe we should call some nurses, one nurse should be follow up the patient day by day, at least using a cell phone, calling day 1, day 2 to ask about all those points to be assessed by the previous slides. And there should be a number for on-call support for outpatient, and all backs, and I've mentioned previously, should be done at the hospital by the trained nurse for outpatient. And maybe we should make handouts for the family as a manual books how to deal with the continuous peripheral nerve block catheter and the machines. The disadvantages of these continuous nerve blocks, of course, we have to get extra equipment, and it means extra costs. For insurance, be careful, especially for state insurance that have a very low budget, I think, compared with the non-government insurance. But otherwise, it can reduce the duration of hospitalization and the needs of hospitalization. So whether it can bring us more cost for the equipment, but it can cutting costs for the hospitalization. And other disadvantages for continuous PNB, we need more time to perform. Single blocks, shorter time. Need more training and experiences, of course. And it's better if using ultrasound. For those who don't have ultrasound, be careful. You have to be very master for assuring that your catheter is on the right side. This is one. Be careful. And then also to secure the fixation of the catheter, that's a very challenging technique. So, should our blocks be continuous? Why not? We have known the advantages, although some disadvantages is there, but I think we can deal with that and we can prevent it and we can make it better, so the complication should not be happen. So, my last message is always stay hungry, stay foolish. After this, if we want to do the continuous peripheral blocks, keep searching for the knowledge, keep training, and keep feeling that we are hungry and we are still do not know nothing. So in the future, we can have more and more knowledge and more benefits for our patient with this continuous peripheral block techniques. Thank you very much for your listening.